But most of all, I also want to acknowledge my institution, Monash University, because they funded the trip for me to be able to come here. So in case I forget to say thank you, I thought I should do this in advance. So we just want to share, this is an epidemiological study that we did in Diepsloot. I will show you some slides and you will understand what Diepsloot is. It's an informal settlement. There is higher migration rate in Johannesburg, people moving from the villages to the urban life. And there is overpopulation of people in particular parts of Johannesburg, and Diepsloot happens to be one of them. Now, it's important to kind of remind people, we know these statistics, we know this data about HIV already, but I thought I should take you logically through the steps so that you can be able to follow what exactly do I really want to present. We know South Africa has quite a high prevalence of HIV, ranked 4th in the world. Estimated 18.8% between 15 to 49 years of age, but 30% in women who are antenatally, or in women who are antenatal attendees. But because this study was based in Gauteng, which is in the central hub of the country, I thought you should also have an idea of the burden of HIV, and it's 16.5% in a population of slightly over 12 million people. But it's also essential to understand the significant variation in the risk of HIV infection between males and females, with females being 1.6 times more likely to be HIV positive. And there are factors that drive those dimensions. And there's wide variation, and that's where I thought we should be together. There's wide variation in prevalence of herpes simplex type 2 among HIV positive and HIV negative women in the ratio of 89 versus 42%. So which means that women who have got HSV are highly likely to acquire HIV infection. And could that be one of the driving factors of HIV in this population? So we had some colleagues who talked about HIV and STI, and it's common knowledge that STIs do drive HIV infection, and in our population, this is a very key factor that we need to consider. And because of that, we thought it's important that we do a study like this one. Now, why do we talk about STI surveillance? Surveillance, like here we are, I know there are cameras here. Some people are sitting somewhere and they are seeing us as we talk. So they are monitoring what we do. So it's essential that we monitor STI in the population because it's a key driving factor of HIV infection. And that's why here we see this data from Gauteng, new STIs from Gauteng. Gauteng is one of the provinces in South Africa. And we can see here, I want to focus on Johannesburg, which is part of Gauteng, 42% of new infection. And this is a population of slightly over 12 million people. So what's happening here? So let's talk, why STIs? Do STIs matter in the control of HIV? Yes, they do, because there's an increase in acquisition and transmission of HIV, as we have been talking about throughout the 3 days. Why? Because treating STIs early do improve mucosal integrity, and therefore that does limit HIV transmission. There's less mucosal inflammation, and so that does control HIV infiltration into the system, and at the same time it lowers the risk of viral load in HIV-positive individuals. It's important to remind each other that STDs, or sexually transmitted diseases, have consequences, and these are some of the broad consequences. One of them that we're talking about now is HIV transmission. A colleague yesterday talked about fertility, impaired fertility. Another colleague talked about cancers, the reproductive tract cancer, like cervical cancer, and also adverse pregnancy outcomes. And therefore, STIs play a very crucial role in the dynamics of the life of people. Now, but there is a key challenge that we need to think about. Asymptomatic STIs. We know about STIs in general, but when STIs are asymptomatic, it means it's difficult to identify them. And so it's a key challenge. And therefore, it's essential that we need to take this into account as we think about how to control HIV infection in the population. But I thought I should show you this. You see this is chlamydia infection, and this is gonococcal. This is a more fulminant acute infection. And having seen STI patients for quite some time, I know exactly if a male patient comes to you with these symptoms, is definitely in pain because of acute urethritis. This is less indolent because it's gradual, and the process, the pathological processes between the two are slightly different. And I thought I should just highlight this because genital ulcers have they do play a major role in HIV transmission. You see, these are ulcerations inside the vaginal canal. And in my area, this LGV, people call it a dynamite. They call it a bomb. Why? Because it's very painful, and it can burst open, leading to chronic ulceration here, or even sinus tracts. But those are critical factors that we think about in terms of how do STIs play a role in HIV transmission. And therefore, we thought with that background, let's go to this population and try to estimate the prevalence of self-report. Why self-report? Is because if people have symptoms, they should be able to report them to the hospital. If they don't have symptoms, possibly they may not report, and they will be a silent, STIs will play like a silent killer, because HIV will continue to move in the population simply because STIs are not being controlled. And we thought we also have to determine the risk factors of self-report. Let's find out what are these factors that do drive STI in this population. And so we used data that was collected through a survey, which was meant for another use. We used that data to do a secondary analysis, and this was an adult population. We looked at 3,953 participants, and we did explore what are the potential factors that lead to self-report, using univariable and multivariable logistic regression models to identify these particular factors. And we reported the effect measures using odds ratios and corresponding 95% confidence intervals. And a p-value of less than 0.05 was used to determine the statistically significant factors. And I thought I should just show you the study site. This is the map of South Africa, and I do like this map because it looks like a sweet potato, so I almost always like to show this map. Where you see this big dot here, that's Gauteng province, and essentially Johannesburg is a city in this province. And deconstructing this map now, this is the Gauteng province, this one here, and this is region A, which is in Johannesburg, and that's where the study actually took place, and this area is what is called Diepsloot. And Johannesburg, like I said, has a population of close to 12 million, slightly above 12 million people. It's important to know the study setting where this study took place. So this is Diepsloot. You can see here, these are some formally constructed homes, but these are informally constructed homes. You know, you move from your village, you find a piece of land, you carry cartons, and you build yourself a home. And in South Africa, these homes are called shacks. I don't know where the name shack came from, but you will understand, or you will know that in Durban, which is Durban has the Indian Ocean, there are a lot of shacks there, and shacks do eat people and kill people, and they kind of try to associate this to be a dangerous area that you can live in. So it is a shack, it's going to eat you. And you will see that across here is more muddled shacks, just like there, and this area, as we see, has close to 200,000 people. So this is a highly densely populated area. And these are some of the people who live there, people who are underprivileged, both economically, socially, and many other factors. Now, what did we find? From this population of study participants, 2,481, representing 62.8%, were females. I don't mean to say that there are 62% females in this population. I'm only saying that the study population that we used had more females than male population. And the prevalence of self-reported STI was 20.4%, representing 808 people of the total population of 3,900. Of the study participants, meaning that population, 25% or nearly 26% of these people were HIV positive. That is quite a very high prevalence of HIV. And among that population, close to 20% had actually reported an STI. That does mean something very significant. So we analyzed the data. I know other people get intimidated with numbers, but what I decided to do was to simplify, deconstruct this table into what are the most relevant findings. So what did we find? So number one, we found that STIs were common in this population, and these are the significant factors that we found. So these factors actually are represented in this table. Males, people who were single, were more likely to report an STI than those that were married or cohabiting. And people who used alcohol were less likely. Actually, people who did not use alcohol, if you are not using alcohol, you are more likely to actually go and report an STI compared to the person who is a binge drinker. So it means alcohol has an effect. And then the most other important factors was prior exposure to gender-based violence was associated with self-report of STI, and also having not utilized healthcare services in the past 2 years. So which means healthcare utilization in this area is very minimal. Now, what information do we get from here? The reported prevalence of self-reported STI among this population indicates a substantial burden of STIs in this population, as we have seen. And drivers of STI in this population, like gender-based violence, alcohol, lack of access to healthcare services, need an effective impact mitigation from all stakeholders. And why did I bring this slide here? In South Africa, we like rugby, and aggression and teamwork achieves success. We need to be aggressive and work together to be able to control HIV infection. So what do we recommend from here? We need continued STI surveillance to keep monitoring the trends of sexually transmitted infection, integration of sexual health and health promotion, this will help to improve health-seeking behavior, and people can effectively report STI symptoms if they have, enhance HIV counseling and testing, as well as screening for STIs. Focusing on the at-risk population is essential. Scaling up behavioral interventions to prevent gender-based violence. I'm not a gender activist, but I know that gender violence in South Africa is very high, and from our study, it is driving STI and HIV infection. But also a policy on alcohol restriction in the province would be essential. And I thought I decided to put that here because the MEC, they are called MEC for the province. They had already put a policy to bar alcohol use on weekends, on Sundays. But that is still being debated as other people actually counter-argued against that policy. There is power in unity and togetherness. To be able to defeat HIV, we need to work together. And so my family and myself do work together. This basically tells you that I'm a husband of one wife. We have one daughter and one son. Thank you. Thank you. And thank you. I thought because I showed you an area with sharks, it doesn't mean that's how Johannesburg looks like. Johannesburg is a beautiful city, and welcome to Johannesburg. Thank you.